All right, so asthma metrics. I've talked with many of you in the past year about the asthma metrics. We've actually been looking at the asthma metrics for almost 2 years now because we did a statewide asthma pilot with the National American Academy of Pediatrics in the main chapter here, 2009 to 2010. We worked with 12 practices, Farmington was one of them, and 50 pediatricians in the state.
Notice? Right there.
Yes, yeah.
I looked right away.
Yeah. The big issue really has been is trying to institute the 2007 National Heart and Lung and Blood Institute asthma guidelines into clinical practice. So the guidelines are, the age groups are subdivided 0 to 4 years, 5 to 11 years, and greater than age 12. Severity, looking at classification, impairment, and risk, looking at control. And spirometry. This is the biggest thing that we're talking about for PTE is adding spirometry to the metrics. 2007 said, yes, we should be doing it for over the age of 5. So we did a national pilot, and we're really looking at optimal care. Do they have asthma control tool used like Act or Tract, stepwise approach to treatment, written action plan, and patients with a flu shot? That was their optimal care. We actually, there's a spirometry measure not included there. We did a lot of work with practices around spirometry. We actually saw a big increase in our optimal care during the pilot from 45 to 75%.
Whoa. Cool.
Use of Act and Tract, and this is chart review data, it's not population based. Use of asthma control test went up to 90%, action plans 90%, and spirometry. I just wanted to bring the slide because I keep hearing, I don't know if we can do spirometry. Practices have been working on spirometry. I know it's a big thing to take on, but we saw an increase from 40 to 65% over the pilot. I just wanted to show this is one hospital-based practice that put a lot of things in place. They went from like 0% to 70%. This is one of the private practices, and you saw their rates go up into the, you can't see it very well, but into the 70%. So there's been a lot of work with selected pediatric groups into getting spirometry in place. So let's go to our pathways to excellence. You have in your handouts the asthma metrics. It has the main health management coalition on top, kind of the grid page, and then you have the asthma measure specification document. We've actually formed we've been talking about this. I know I presented about this many times in the past when I've been on the phone. We've had a subgroup working on these. So Steve Giovanni, Mike Ross, Barbara Chamanzik, who is the allergy immunologist down in Portland, who's the medical director for the AW program, which is statewide as well as she was actually nationally recognized for all of her work in asthma with the National AAP project, and lots of others. There's been sort of a cast of many characters doing this with us. So what we're basically asking for PTE is that PTE adopt spirometry into the metrics for ages 5 to 18 at least every 2 years, and we'll go through these in a minute. That we also look at the age group of 2 to less than 5, so we're adding that into the age category because that's the age category that's the most high cost in terms of hospitalizations and emergency room visits. And part of the shift in moving to try to move from chart review to population-based health is really re-looking at the metrics that PTE had and looking at the national metrics so that we can come up with specifications that people can build into your registries that are consistent across the healthcare systems. Because one of the things that we found with all of these metrics is that if there's ambiguity, then there's questions. And with PTE before is basically a chart review, and what we're really trying to do is move to a really standardized process for measurement. So we looked at, we can send these around if anyone has questions, the current PTE asthma metrics, the bridges to excellence, the asthma metrics, which are really age 5 to 75, so it's mostly adults, the national quality forum metrics, which most are coming out of the AMA and NCQA, and then meaningful use. We attempted to align the numerators and denominators as much as possible. Part of the issue when you look at national metrics is that none of the denominators match up. They're all at different age groups. Some start what is their age at the beginning of their reporting period, some is the age at the end of the reporting period. So what we've tried to do is line up numerators and denominators and make things as clear as we can so that if you're going to build them into your registries, everybody's collecting the same data. That is a challenge because all these different sources are a little bit different. So that's what we've been working on with this work group over the past 6 months to try to come to some consensus and keep the age groups as simple as possible. One of the things I was saying with NHLBI guidelines is they broke them out to 2 to 5 and then 5 to 11 and then 12 and up. we went out and asked the healthcare systems and the data people, they said they would rather us actually keep it to 2 age groups, 2 to 5 and then 5 to 18, to keep it simpler, and if they want it broken down more, they can. And I say that because one of the meaningful use metrics, that's how it's broken down. So in front of you, you have what we are currently hoping for a vote today in terms of the asthma measures here. And you'll see that there are points for each metric. These actually came from the Bridges to Excellence document as kind of a basis of what points you would get for each measure. But when we were looking at from a pediatric side and what's happening from registries and what data we currently have, some of the groups initially came back and said, well, we're never going to get best. We're never going to reach these targets. Our spirometry is not going to be 90%. You know, we're down at 6%. How are we going to get there for PTE? This isn't really fair. We're doing a lot of work. You know, so there's most of the pediatric groups, everyone is agreeing with the metrics. It was really the points and the ranking that was where all the conversations seemed to be. So what we did is we sat down with the work group, including Dr. Shimontzik, our asthma expert. We sat down with some data people from different healthcare systems, and many of them have some of these metrics into their registries already. We looked at where practices were falling currently. What's really, if you are the best high-performing practice in the state, what would we really expect for the metrics? And I just want to explain this to you because this is what I seem to be emailing a lot right now. So for asthma assessment, if you are best practice, you would be at about 80% using ActorTrack. Lung function testing. The best practices in the state are obviously probably the allergy, immunology, pulmonology groups. They're probably at 95%. But for primary care, they're ranging from 6% to 50%. The best practices we're looking at are around 50% for spirometry. Medication therapy, 90%. Influenza vaccine, that's ranging around 65% to 70%. Many of the healthcare systems have put a goal of 75% for influenza vaccine for children with asthma, and that's how we came to that. Self-management, 75%, documented tobacco use or exposure, 75%, and BMI. And then we took the maximum points that you could get, and then we times them together. We looked and said, if you got a 76, if you reached all of the best with the maximum points, you get a 76. So that's how we came out with the best was 75. You will notice we also have a corrector for the population-based, and they add 10 points if they're doing population-based reporting. So we have looked at some of the groups who are doing high-quality asthma in the state, and we've found that many of them are following in the better and best categories. Saying that, this is a little bit inexact at this point, because as we're coming out with the specifications, some of them are going to have to redo their registries a little bit to match up with the metrics point. But I just wanted to let you know that we understand that not everyone's going to be at 100% for spirometry. That keeps coming up. Our goal is to get people to start to implement things and get things in place so that the guidelines are actually being followed. The other issue that we're coming up with spirometry is that some of the insurers are not paying for it. So even though it is recommended nationally, they should have it done at least every 2 years. BT is paying it for it yearly. We've got many reports that the insurers are not paying for it, so parents are left with bills of $80 to $150. And so when a parent comes in the next time to have spirometry done, they're saying, we don't want it because we don't want the bill. Bring it up as you are the main health management coalition. This is a huge issue for our practices because they want to follow the guidelines, but they're getting stuck into the billing process of this.
That's shocking.
Shocking, but very true.